You are welcome to this talk, and I'm delighted to welcome back the channel's favourite general practitioner, Dr. Michael Cohen. Michael, thank you so much for coming back on.
Oh, you're welcome. It's lovely to see you.
Now, this is going to be a new series called N equals 1, Michael. Is it about algebra?
Not quite, but it comes from algebra. I imagine quite a few of the people who watch your channel know that in medicine there's this concept of N equals 1, which is basically that when somebody, when we don't have large-scale research, we're basically saying, well, we've got a patient with a particular problem, and how do we approach this problem and individualize it to that patient? And if we get results, whether they be positive or negative, that becomes a trial in itself just on that one patient. So I can say as a family doctor I've been a doctor now for nearly 30 years. And I can say as a family doctor specifically, but also in other situations, the approach I try to take is to say, well, actually, what's actually going on here? Why is this specific person got this specific problem? So as opposed to having a generic response, which is, okay, well, you have this and we have all these guidelines, it's to actually look and say, well, hold on, what's going on with this very specific person? Why does this person need medications, or do they need something else? Do we need to find out what's underlying the problem?
Individualized, bespoke.
Yeah, it's very much about literally trying to. It's about asking why. It's and just trying to get to the bottom of the actual problem.
Yeah, and generally in medicine at the moment, do you see sort of a stereotyping, a collectivization, we must follow the guidelines sort of approach? Is that problem you've perceived?
I think that over the years I've seen more and more, and I can understand the reasons why. It's to standardize care, it's to raise the minimum standard of care, it's to make sure that everyone's getting the minimum basic care. The problem with it is that it compartmentalizes everything into you follow this route or that route or that route, and it's all according to evidence-based guidelines. But the problem with evidence-based guidelines is also that they can miss things, and not, we do respond differently. Our bodies are different. Everyone's genetic is different. Our environments are different. Our microbiomes are different. So all of these factors come into play, and they can impact, two people can take the same medication, and one person will respond in this way and one person will respond in that way, or not respond. So it's really about trying to say, well, what is it specifically about this person, and what can I do in order to do no harm? As the Hippocratic Oath says, first do no harm. And so by following guidelines, but also stretching things a little bit and saying, well, hold on a second, what do I do with this specific person?
And it lets you use your medical experience and that sort of intuition you get after working with patients for many years.
For sure.
To do what that patient needs fairly specifically. Yeah?
Absolutely.
Assessing, planning, implementing and evaluating on the specific individual patient rather than just the guidelines. Because if we were just following guidelines, we could get rid of doctors and just have an AI algorithm to an extent, couldn't we?
Well, I think we're going that direction, I think. I do think that there is a lot of room, when you've got the experience, to actually start asking more serious questions that can actually help an individual.
So that's what this N equals 1 series is about. It's about individualized care. And we have specifically agreed that you wouldn't reveal the topic of today's subject to me until I guess about now. The reason for this is so that I can learn with the viewer, and we can learn from you as we go along. So the big reveal, Michael, what is today's topic, please?
Okay. So I thought today's topic could be something that affects a lot of people, which is infertility. And it's a very big subject. I can go into it in detail, the female side, the male side. I'm going to just focus at the moment on one very specific aspect of it, and that is the effect of low iron levels on fertility.
Wow.
Normally speaking, when people have gone through a process of trying for a baby, and it depends on what age they are, if the woman is on the younger side or slightly older, there's a whole process that eventually could result in them receiving hormonal treatment. So in vitro fertilization, it's called IVF. And there are all sorts of different hormonal treatments that can be used, and if they don't work, it can progress on to other more complex treatments, more invasive treatments, more complicated treatments, more risky treatments. And I have found over the years that quite a lot of couples have very straightforward problems that can be addressed, that can avoid them going down the route of needing hormones. One of the common things that I found is to do with iron levels. Now, women in general have lower iron levels just because they menstruate every month. So by through that mechanism, they're losing iron and they're losing other important minerals, vitamins, etc. every month. And although I'm going to focus today just talking about iron, it's important to say that there's other things that I also look at. It's not just their iron levels. So maybe looking at some of their vitamin levels. But the crucial thing to mention is that when they may be first seen by their doctor, they have a typically normal blood count. So they can have their haemoglobin level, which is the molecule that carries the oxygen in the blood, may seem like it's at a normal level, and all the other indices around that, the size of the red cells, the distribution of the size of the red cells, all the other markers may indicate that everything's normal. But it's only if you actually start doing further tests, and quite simple tests, looking at their ferritin levels. Their ferritin level is, ferritin's a protein which is bound to iron. And you need to know how to interpret it, of course, but when their ferritin is low, they can still have a normal blood count, but they're actually deficient in iron. And there are other indices, there's something called the transferrin and transferrin saturation. And by interpreting these things, plus some other vitamins and minerals, you can come to a much more nuanced picture about what's going on with this person. And it's crucial to try and correct any deficiencies.
So these are things that might not show up in routine blood tests that most GPs will carry out?
Unless you're specifically looking for them, no.
Right.
Most of the time, they won't necessarily do a ferritin level. Even if they do a ferritin level, you could have a normal ferritin. Now, if you look at lab values are based on the population of the patient. So if the population is, let's say, women of childbearing age, then by definition, they're going to have lower levels of ferritin. And that's going to be seen as the norm. So that's what the lab will represent. And so if you look at a lot of lab values, you'll see that the normal range for ferritin is, I think, somewhere from 13 and upwards. Now, the reality is that unless you've got a ferritin of at least 30, and I would say probably around 50, you are likely deficient in iron, or you are deficient at the point that when you need iron in your body, you haven't got enough, you haven't got the reserves. And that has a number of effects on fertility. So firstly, you've got the ability of the body to produce healthy eggs. Now, if you haven't got enough iron, then you can have a picture whereby a woman is menstruating normally. They're having regular periods, but they have a subclinical. They have a deficiency that's causing a less than optimal type of egg production. So the egg quality may be less than. It may be less good than it should be or could be.
So adequate iron is necessary for normal ovum maturation prior to
ovulation. I mean, adequate iron is important for virtually everything in the body. Iron is responsible in the electron transport chain and in the mitochondria of the cells. It's important for energy production, for ATP production. And so someone who's got a subclinical lack of ATP, let's say, is running on empty. And as a result, the enzymes in the mitochondria don't work so well, and the utilization of oxygen is just not as good. And as a result, you also don't get a good follicular recruitment. The follicles, the eggs themselves don't get recruited well. Steroid hormone synthesis is down. And all of these things put together compromise the ability of the woman to conceive just from the point of view of the eggs. Then the next step of things would be the actual the endometrium. So the endometrium is the cell, is the layer of the womb which bleeds. When a woman bleeds every month, they're losing that layer of the womb because it's supposed to proliferate and then become receptive to the eggs. But if you've got an iron deficiency, again, it may not be obvious that you've got an iron deficiency. Then what actually happens is that the function of the cells in that layer of the womb is actually compromised. So the layer may be thinner than it should be. It's got less blood vessels in it, so it's less vascularized. And so this means that even if you get an egg that has met a sperm and they are starting to make an embryo, the embryo doesn't implant well into the womb. So there's a number of different mechanisms at play there. And again, this is another thing that results in inadequate fertility. And then the last thing is also about embryo development. So an embryo that's lacking in iron, you've got a low oxygen environment. Instead of having sufficient levels of oxygen and ATP production, etc., you're going to get eggs which are of a lower quality, and the embryos themselves are less likely to survive. So these are all reasons why iron is so important. And we're talking about this as N equals 1. I've actually had many patients over the years who are literally about to go and see fertility specialists, or had even seen fertility specialists, and they were about to be started on a whole program of hormonal treatments. And some of these treatments really have sometimes side effects that can be quite dangerous.
You mentioned before more invasive treatments, but severe manipulation of hormones through exogenous means of giving out artificial hormones is actually quite an invasive thing to do, really.
It is, and it has, women feel it, apart from the fact that it can just affect their mood, you can result in a situation called ovarian hyperstimulation, which can be pretty dangerous. It's not pleasant, and it's not natural. So I found many times I've said to people, look, just slow down for a second. Let's just do some basic tests over here. And I can tell you one that's coming to mind right now of a couple who were trying for children, and they weren't succeeding. They'd gone to see some top specialists, and the specialists had come up with a program. They say, we're going to do this, this, and this, and you're going to get hormones, etc. And I said, look, just do a couple of things. And we checked a couple of, we checked their iron levels, of course, but other vitamins and minerals. And I said, look, you've got a bit of a deficiency here. I said, just take iron, and there was a couple of other vitamins as well. And do you know what? I never saw that couple again for something like 5 years. For various reasons. I think they moved out of the country, and they came back. And then the guy comes back to see me one day, and I thought I'd done something wrong, or I'd offended them or something. Yeah. And I said, how are you and everything. He says, you never believe it. He said, we never saw the specialist in the end, and we never had the treatment. He said, but we took the iron and the vitamins and everything, and we had twins.
Fantastic.
And I think they then had a third child after that as well. And I think that it says a lot, and they're one of many stories that I can say that have this outcome.
You're going to have to give us a clue about these other vitamins and minerals, Michael.
For sure. I mean, they are, again, it's about going into the basics.
Common ones.
The common ones could be vitamin D. A lot of people are deficient in vitamin D. I can't tell you that I've done heavy research to say, but it wouldn't surprise me if vitamin D was not important in embryo development, in becoming pregnant in the first place.
Bees, I would imagine.
Bees.
Vitamin Bs.
Vitamin Bs are important for a lot of things. So yes, I mean, you're trying to get a situation whereby both the woman and the man have a fully functioning body.
Yes.
And what do I mean by that? You want their cellular function to be working at its best. And even if you make all of these changes, it doesn't mean that everything will be fine. But at the very least, you've given them the physiological background which they need in order to function. Their cells need to function at their most optimal way.
Yeah.
And if you don't do these very basic things, then everything else, I liken it to having a car which is struggling to ignite the engine. You're turning the key, and the spark plugs are going, and it's going but there's not enough fuel in the engine.
Yeah.
And literally, it's about making sure there's enough fuel in the engine. If you've got all the right fuel in the engine, then the spark plugs, a car in that situation with, let's say, less fuel would work, but may not work as efficiently, etc. And it's simply about making sure that you've got all the elements for the cylinders to be firing, let's say.
So these women that might be a little low on ferritin, a little low on iron, I mean, they're not coming in like short of breath with heart failure and tachycardia and
absolutely not.
And, and white sclera. I mean, no. This is like a subtle subclinical.
It's a very subtle subclinical thing, and that's, I think, one of the reasons why it's so often not thought about. When they see a normal blood count, it's like, yeah, you're normal. Okay, now, what else can we do here? We've got a protocol. And even when they're seen, and let's say someone were to check their ferritin level, if the lab value of ferritin was 14, well, that's technically normal. So, you don't need to do anything about that necessarily. And it could even be in a woman who's taking iron supplements or who eats sufficient amounts of meat, but they've got an absorption problem in their stomach for various reasons, or they are losing enough blood every month that the level that they have is sustained, but it's not enough.
Yeah, because they're using it up every month to make more blood to compensate for the loss from the menstruation. Yeah. So for most people, if they eat more iron, is that going to increase the ferritin levels without doing anything else?
It will help, but unless you actually measure, then you don't know. That's the point. It's not enough. And the other thing is with ferritin is it's also an acute phase reactant protein, which means that if I have the flu at the moment, my ferritin will jump up. But it doesn't mean that I've got enough iron. It's a reflection of something else going on in the body, some inflammatory process. So you need to know to not be deceived by it. And the other thing is you may have a relatively normal ferritin, but you may have a low transferrin saturation. So it's about interpreting the whole picture and making sure that you understand what you're looking at.
So the transferrin saturation, is that to do with iron metabolism as well?
Yeah, and you need to see that there is enough. That the transferrin protein is being saturated to an adequate level. All of these things are about having enough reserves. So what does that mean? It means that, if you've got an apparently normal haemoglobin, it means that technically you've got enough red cells. But if you have not got enough of these other indices, meaning that the iron in your body is filling up in the red cells, then you have a situation whereby it's subclinical, so you're not seeing an obvious anemia, but what you are seeing is a poorly functioning system.
And what it also means is that everyone thinks of the function of iron as producing haemoglobin, but it means iron has more functions in the body as well as producing haemoglobin. Absolutely. Yeah.
And this reserve function, I want to come back to, is so important because, you can have enough. Let's say I was a completely sedentary individual and I'm sitting down all day. So my iron levels may be more than fine for what I'm doing. But as soon as I start running, or if I have other demands, or I'm using my brain too much, or I am trying to get pregnant, it's a whole different kettle of fish. And you need to have the reserves there, because if the reserves aren't there, then you just don't have enough when your body actually needs it in all the places that it needs it, which is pretty much for every cell.
And this is such a good example of thinking of the simple things first. So, some doctors have learnt about the clever things about hormonal treatments and the more sophisticated interventions. But we should always try and optimize the basic things first. Let's get rid of the really basic variables, which are very simple to do, cost essentially nothing to do.
Yeah.
And then probably 7 or 8 times out of 10, that will be enough. That will work. And then we can keep the more sophisticated treatments for the 20-30% that actually need it. But most people can be corrected just with really basic, very simple, almost natural interventions.
Yeah, I mean, these are natural interventions. I mean, the fact that you're taking iron is maybe because you're not eating enough meat, or you've gotten into a situation that for so long you've not had enough iron that just eating meat isn't going to cut it. It's not going to get your levels high enough.
Has there been any studies in this on iron specifically? Or I mean, it's clear, we've always known, of course, that women that are malnourished are going to have reduced ability to conceive, but has anyone actually studied iron specifically? And
there are studies, and I can send you the links. I have read studies that show very clear associations. I mean, people who have, if women as a population have an iron level, ferritin level below 30. Okay, so technically normal, but below 30, they have something like a 40% reduced chance of actually getting pregnant or maintaining a pregnancy through to the end. That's a huge thing. Now, there are many, if I look at all my patients, loads and loads of people have ferritins that are technically normal below 30. Now, if they were trying to get pregnant, I'd be telling them, listen, you've got to get your levels up.
Yeah. So any couples that are struggling to conceive that might be watching this program, what advice would we give them to take to their general practitioners or their doctors to get tested?
So I would advise them to ask their GP to check, obviously, their full blood count. So the FBC or CBC, as they call it in the United States.
So that's the white cells and the red cells, isn't it?
That's the red cells. That's the white cells. It's a whole bunch of indices called the RDW, the red cell distribution width, the MCHC, the level of haemoglobin in the red cells, etc.
What sort of condition the red cells are in?
Yeah. And I would want them to get their ferritin level checked, their transferrin saturation. I would always tell them to ask them to get their vitamin B12 level, folic acid, vitamin D, and magnesium, and thyroid function. These are basic things. There are other things that we could go into. They should have their sugar levels checked as well. But how far do you want to take this conversation? It's that's a real list for women. It's a very basic.
To take to their doctor and say, doctor, do you think it's worth checking these basic variables before we go to a more invasive intervention?
Correct. In addition, I don't want to leave the men out of this. I mean, I would also want to make sure. I'd want to make sure the men had a sperm test as well to make sure they've got adequate levels of sperm, motile sperm, etc. And we could do another video just about that, because that's also there's a whole bunch of things that can help men to improve the chance of the woman getting pregnant in the first place. Right? It's not always the woman, or it's not only the woman by any means.
We don't want Henry VIII syndrome, blaming the woman all the time. That would be
absolutely not.
Completely unacceptable. Just one thing there. Mentioned folic acid. I would quite like to substitute methyl folate instead of folic acid.
Absolutely, yes. I'm sorry, I didn't specify. I would also say methylcobalamin as opposed to.
This is years of habit, because I've done some work with Tim Kelly and Claire Craig, and folic acid is actually a man-made version.
Yes, it is.
I much prefer the God-made natural version of the methyl folate. So.
Agreed, 100%. And there have been studies that shown that folic acid can be given in an overdose, as it were, and it can actually be detrimental. So I would always say yes. So when I say folic acid, the level you're asking to be tested is the folic acid. They're not testing your methyl folate level, but the supplement that would normally be given in addition to eating plenty of green vegetables and leafy green vegetables would be methyl folate as opposed to folic acid. And the same thing with B12. I would say the same thing. Again, I don't give my patients cyanocobalamin, which is the synthesized version, but more methylcobalamin, which is the way, let's say, nature intended.
Yeah, the methylated form. It makes it easier for the body to use it as well, doesn't it? Yeah.
Absolutely.
Yeah, yeah. Well, I think that's an excellent example, Michael, of just really basic things that so often aren't done. There's so much ill health around the world, and if people could just make a simple intervention very often, that's going to dramatically improve their health, and in this case, improve the health of the next generation. I mean, I'd kind of like to add a couple of other points there, really. I taught a lesson for a couple of decades called periconceptual health. Optimizing, so if a couple are trying for a baby, optimizing the health of the mother and the father.
Yeah.
But for example, not a lot of people know that if the father's smoking when the sperm is being produced, that can actually increase the chances of mutation in the DNA in the sperm, potentially causing cancer in the child, which is really quite unthinkable. So dads, optimize your health. Don't smoke, cut out the booze, healthy diet, healthy lifestyle. You want absolutely tip-top quality sperm for the next generation that's not damaged in any way.
And just to add to that, again, it's about doing these things consistently for a period of time. And well before you actually conceive, because you want the sperm that's actually being produced to be of the highest quality.
Absolutely.
But smoking is definitely one of those things, and we know that it affects the sperm through epigenetics. So it turns on certain genes, turns off certain genes. And yes, same thing with alcohol. And by the way, same thing probably with too much stress, and
that's harder to deal with.
Sleeping well, it is harder to deal with, but it's something to take into
to bear in mind.
Yeah.
And for mum, obviously the methyl folate is an important one. The vitamin B's is important. The other one I think's often neglected is iodine. Iodine, which is essential for the formation of the nervous system. It's always worth thinking about these. Is mum eating seaweed or some fish occasionally, or
or iodized salt?
Yeah, indeed. The amount of iodine in iodized salt is actually quite low, though. So. It's just something to think about, because basically iodine only comes from the sea. Are people getting some food from the sea? In coastal communities, not so much of a problem. Inland communities, it can be a problem. But optimizing the health of the mother in every possible way prior to conception, and avoiding any drugs that can possibly be avoided. Of course, some drugs are necessary. But
the other thing with iodine is that it's actually very easy to supplement. If you're not getting enough iodine from fish, you can get. I'm not going to go into dosing over here or whatever. It's something that should be discussed with your doctor.
Yeah, absolutely.
But one of the things that we mentioned was checking for TSH, checking your thyroid stimulating hormone level, which they should do anyway. And you want to keep it on the low side, so below 2.5 before and throughout pregnancy. That also has an effect on there is evidence that has an effect on the neurodevelopment of the embryo, of the child.
Yes, because if the TSH is low, that means that the thyroid hormone is actually adequate.
Yes,
and thyroid hormone is going to be necessary for every aspect of metabolism that's generating the tissues of the next generation. Yeah.
To come back to your point earlier, though, what you said about men's health and everything, which obviously is incredibly important. I did also want to add, many times over the years, when I've seen couples and everything is apparently fine, and they have this a label of unexplained infertility, and then the next step is going to be hormones. I really can't count how many times I've told people, listen, just everything's fine. Go now and just enjoy yourselves. As in, I'm not going to go into the details of what that means, but I think your viewers, you know what I mean. The birds and the bees, and the amount of times that people just they stopped trying so hard, and they just went out, had a good time together, and they got pregnant. And it was that.
Basically just relaxing together as a couple.
But that's often, these things are often not mentioned to patients, and so it goes very much to the medical route. So we have to be very medicalized about things. But before you go into anything hormonal, obviously you need to take advice very specifically. Everyone's age is different, their medical backgrounds are different. I'm not saying you shouldn't see specialists, absolutely go ahead and see whoever you need to see. This is a very important subject. But yes, go enjoy the process together. Absolutely. And very often people do actually get pregnant and maintain a healthy pregnancy.
Yeah, and if both members of the couple are more relaxed, things are likely to work much better. Do you advise, if someone's still struggling, say that this advice has followed after a few months, would you advise the times of attempted conception throughout the menstrual cycle? Would you like to focus on days sort of 10, 11, 12?
Well, I mean, you need to know what the length of their menstrual cycle is, but yes, you want to be focusing around the time of ovulation, and probably every second day around the time of ovulation, not every day, because you don't want to deplete their sperm count completely. But yes, to be very focused about that for sure. And again, not to go into too much detail, but to enjoy it. It's supposed to be, it can be and should be something beautiful, and not something stressed and tense.
Absolutely.
And very often I think when people are stressed with work, etc., they they make it like a timetable. Okay, now we have to we have to do the work, but it should be something loving and meaningful.
Absolutely.
And
even
I'm
spontaneous.
Yeah.
And ovulation typically occurs about 14 days before the onset of the next menstrual period. So if cycles are regularly, say, 30 days, then ovulation's probably occurring about day 16. Do not, under any circumstances, use this as a method of contraception. This is advice purely for optimizing conception.
I won't ask where that advice comes from, but yes.
No, we're not in the advice of giving contraception here. This is completely the converse of that. Now, what wonderful topic, but causes real distress to huge numbers of people. Yeah. And I think you've shown through this really quite simple principles, very often unnecessary distress to many couples around the world. So. Thank you so much for that, and we will look forward to the next N=1, individualization of patient care. As always, thank you, Michael. Yeah, thank you so much.
You're welcome. Bye-bye.
Thank you. Bye.